Okay, I think we might make a start. So, firstly, thank you so much for coming to this session. We're quietly chuffed that it's overflowing. I know it's probably not the best OH&S standards, but we'll take that. So, firstly, thank you very much for coming to this session on priorities for education, training and a future-proof health workforce. My name is Professor Dragan Ilic, and I'll be co-chairing this session along with Professor Rebecca Ivers from the University of New South Wales. Just before we begin, I would like to acknowledge the traditional owners of Naarm, the people of the Kulin Nations, on whose country we are currently gathering on for this event. We wanted to acknowledge that we pay our respects to their elders, past, present, and to the elders of all First Nations communities that are joining us today. In particular, would like to extend our acknowledgement to all First Nations peoples and recognise their unique, crucial and enduring contributions to the societies over the world. We've got a wonderful session, so a jam-packed 90 minutes. We've got 4 fabulous speakers. William May from FNU, Fiji National University, Augustin Kusumayati from a number of organisations, but I'll highlight Universitas Indonesia, Rahina Joshi from the University of New South Wales, and John Calidor also from the University of New South Wales. We've got hopefully an exciting format. We've got 4 speakers that will talk for a little while. We'll have a bit of a panel discussion, and then what we're hoping to do is hand over to you guys and have you contribute. So originally we thought we'd get maybe not so many people, so we set it up in a cabaret format. So we're hoping for some small group work, but we are flexible. We've created something online, and I've lost my doobie, but we'll get back to that in a short sharp, so don't worry about that for now. If we can go on to the next slide. And I'll shortly have William come up, but before I do, I'll hand over to Rebecca to lay out the land for the session. Cheers.
Thanks, Dragan, and great to see so many people here. As Dragan said, I'm delighted to see so many people here, so many friends and colleagues. And as Dragan said, we've got an amazing lineup here. And I too would like to acknowledge the traditional owners, the land we're meeting in of this unceded Aboriginal land. So, health workforce, really, really important. We know that the whole Asia-Pacific region is undergoing rapid demographic, epidemiological and technological transformations. And we know that's really important, that we therefore have a skilled and adaptable health workforce across the region to keep up with that, but importantly to achieve sustainable, equitable health outcomes and universal health coverage. So that is key. The ILO, the International Labour Organisation, estimated in 2021 there were 47 million working in health and social sectors in the Asia-Pacific. But we know that there's huge variation in health professionals across the region. Issues to do with exploitation and brain drain of health professionals and variation in salary and working conditions across the region, leaving many countries with gaps in staffing. And of course, in the region, me as an Australian, have to acknowledge the role that Australia and New Zealand plays in that. But it is something that is, it operates across the region. Further, we've got challenges in terms of shifts in the health profile and the challenges that we face, including an ageing population, threats from NCDs and climate change. So the mix of health professionals and caregivers in the region also needs to change over time, including surge workforce to deal with health emergencies and pandemics. But it's more than just health professionals, doctors, nurses, clinicians, dentists, and everyone else. It's also the public health workforce. And so that's actually something that's very poorly documented across the region. It's not very clear who the epidemiologists, data and analysts, the health promotion people, the communication experts, who we need and what we need going forward. So some of the organisations that we're engaged with, I'm chair of CAPHIA, the Council of Academic Public Health Institutes Australasia. Augustine is the chair of the Asia Pacific Consortium of Academic Public Health, and we're working together on furthering the development of public health competencies. And Augustine's going to talk a little bit more about the really important work that they're doing to make sure that we do have a skilled workforce, but importantly that we know what the public health competencies are, that we have employment pathways for graduates. I also need to note, and we won't be talking about it specifically necessarily in this session, but we also need to be mindful that in Australia, training and pathways for First Nations populations is also critical. There's a lot that we can learn in terms of knowledge exchange from First Nations populations in Australia, but also from people across the region. And it's something for all of us to be sure that we have equitable, culturally safe frameworks and pathways, not just outside Australia, but inside Australia as well, and keeping a focus on that is something that's critical. So I'm going to hand over now to William May to kick off. As we're not going to do long bios. You can all read that in the app. There's very long, detailed biographies in the app, so I encourage you to look those up. But of course, Professor William May is a really important person in the region. He's immediate ex-dean of the College of Medicine, Nursing and Health Sciences at Fiji National University, and a really important partner and leader in the region. So over to you, William. Thank you very much.
Thank you very much, Rebecca, for that introduction, and thank you to the organisers of this World Health Summit Regional Meeting for inviting us to be part of this session. I'm going to talk to you about our experience from a training institution perspective for the South Pacific, and share some insights on how, what we think or how we think this could be addressed. And I'll do that in 10 minutes. Yes, so a brief on the screen there is the area of the Pacific Island countries we look after, and we train the workforce for the future. And we've been doing this business for the last 140 years. Come next year, that'll be 140 years in this business. So from a medical school that have been threatened a few times to be closed, we've survived over the years and training the workforce, for the Pacific Island country, far north right up to the Northern Pacific Islands, and also far south to Tonga, the Kingdom of Tonga. And also 1% to 2% of our students are international students from New Zealand and Australia, with some from India and Asian countries as well. Just on a brief background on the numbers that we're looking at in here, and I just want you to pay close attention to the bottom line in there. On average, we train in the College of Medicine, Nursing and Health Sciences and Public Health in Fiji, about 2,600 average. It goes up to 2,800 students enrollment per year, full-time equivalents, students across the 5 schools. And majority of our students, 75%, are females. Yes, 20% of our programs are postgraduates and about 80% are undergraduate. We've started our HDR program, and that's about 1% to 2%. So the figure to be looking at is 2,600, because that will become very useful to know when you look at the immigration of workers or the resignations. This is a slide from SPC of September last year, looking at where we were 10 years from 2023. So in 2012, out of all the 14 Pacific Island countries, we had only about 676 doctors employed by the Ministry of Health, which is about 3 doctors per 10,000 population in 2012. 10 years something happened, and then we doubled that figure, more than 100%, 134% increase in our workforce, doctors in particular, this is excluding nurses and all other allied health workers, to 6 per 10,000. 134% increase, and this is because of the training that were opened up, in all over the world, free to the Pacific Island countries, Cuba, China, and other areas. So the influx of foreign trained doctors, while they assisted in the workforce, there were other issues, that were involved with these trainees when they come, to our countries, apart from the language and the way they were trained. But that's the numbers that we were looking at, in 2023, and the workforce in comparison to what you got here in Australia and New Zealand, and of course Cuba, far below where the neighboring countries are today. In yellow there in 2023 is another depiction of the graph. Most Pacific Island countries, doctors just increased like that in 10 years. And some, did not really increase. But having said that, they were well above the recommended 10 per 10,000 from WHO. So it's a trend all across the country. So we were enjoying that, increase in number of doctors in the provision of services. When I looked at the Ministry of Health Fiji only, and I hope you'll try and reflect this in your own country and looking at your workforce, the nurses make up close to 50% of our health workforce in Fiji, and then the doctors make up 16% and the rest by other health workers in the country. When we look at the resignation trend over the past 5 years to last year, it's very interesting here that we lost 2,306 health workers. So you transpose that on the number of enrollments we have all across in all programs, that's close to like a year of the students you have in your school that have left the country. Yeah? And that's almost like half of what we graduate across the college in one single year lost out of the country. So when we looked at nursing, we lost 1,584 nurses in 5 years, and the establishment for nurses in our country is 3,500. So we've lost an equivalent of 44% of our nursing establishment in the country. Yeah? And they've gone everywhere. They've gone local private settings, they've gone New Zealand, Australia, and also regional countries as well. Whereas medical officers, we've lost about 26% of the equivalence of the establishment we had. And you look at 2 programs there in asterisk, and they suffered, quite a high immigration as well, because these 2 programs are actually accredited, one accredited by New Zealand and one accredited by Australia. And the rest of the programs, or allied health and environmental health and public health workers, are not immune to the problem. So the resignation rates were triggered in 2022 as soon as the borders were open. Everybody started looking and searching. And that sort of slowed down last year to a reduction of about 20%. I hope, my own personal opinion is that it's going to slow down a wee bit for nurses again this year, and that's because the government has stepped in to try and restabilize the salary, and remuneration for nurses. So I would envisage that this year it might be slowed down, but I'm hoping. Thank you. When you look at the trend for other health workers, it's the same. It's basically the same. Something happened in 2022, and I would imagine that other Pacific Island countries, Tonga, Samoa, Papua New Guinea, Solomon Islands, and Vanuatu would be experiencing the same thing as well. Now back to nurses in the country. We're quite privileged that we've got 3 training institutions in the country for nurses. We produced approximately 260 nurses per year. Our institution graduate about half of those numbers, and another 50% by the 2 other training institutions. If we look at the number of doctors we've trained, and graduated from 2018 to 2022, an average of about 60 doctors, 60 local doctors. 12 to 23% of those are Pacific Island country doctors. Only about 60 in numbers are local graduates that we graduate. Over the last 5 years, 325 doctors have resigned from the public health service, and majority of these are junior level positions, and 83% resigned in the last 3 years. So if you look at it, we graduated 304 local doctors from 2018 to 2022. So in actual fact, in other words, the public service has lost an equivalent of all that we've produced in the last 5 years. So you ask us, then where did we get the replacement from? The beauty is that we've got another private medical school that probably graduates some doctors at that time to try and cushion, the holes that have been produced with the migration of doctors from the health workforce or public health service. Nurses is very interesting in here. If we look at the numbers, if we replace the number of nurses only that have left the country, it will take the 3 institutions 6 years to replace the numbers. That is, if we don't allow anybody else to move out of country between now or 3 months ago to the next 4+ years. But that's not going to happen. So if we set up a nursing institution that takes in about 100 students, we can shorten that gap by 1 year, and and at the same time replace, but we have an excess of somewhat to try and cushion the continuous trend of migration. And I'm talking about numbers only. That's not skill replacement and experience replacements. So solutions, I don't really know the answers, but I know there are some possible, short-term solutions to this. There are medium-term solutions, and of course some long-term solutions to address these problems of migration. Whether we task shift, or whether we share, or we continue training and continue to train more, and address the other underlying issues regarding environment, finance, remuneration, etc. But I would like to make this message clear and loud today, that I think all of us in this room here who are not from the Pacific Island countries in a region have a responsibility to these island nations. And I think richer countries that are receiving our workers that we've invested in as migrants from what we call low economically resourced countries should adopt some responsible recruitment policies and consider entering bilateral agreements as recommended by WHO. And I introduce you to a term, reciprocity. We need to give back to country, and it must be proportionate and measured to the equivalence of the benefits that you're getting from health workforce Pacific Island countries, and in whatever form, whether you address that through the ministries of health, like capacity building for the young leaders that are taking up positions, or you address that through the training institutions, or some kind of agreements that, as a form of responsibility back to poorer Pacific Island countries who have lost their workforce from the region. And that's my last slide in 10 minutes. I know that WHO has put out recommendations for responsible migration and agreements, and I would like to see this being implemented across Pacific Island countries, and for Pacific Island countries to be more assertive as well in recognition of the current problem they actually face, because it's a huge problem for the service, for our people. So thank you very much for your attention, and I'm happy to take questions later on. Thank you.
I mean, that was incredibly powerful. Thank you so much. And I think I do wonder, and I think keep this thought for the World Health Summit, if we actually have conference resolutions. I think you've just provided us with the first conference resolution there. It's something that's incredibly important. I think when we think about what to do as advocacy, and it would be lovely if Penny Wong was in the room now, but I think we can make sure that she hears that message loud and clear. So thank you. That's really important. And not to mention the cost to the universities in the region of providing. It's not just about losing skilled workforce, it's the incredible costs that goes into actually training people up. We provide aid from Australia, or supportive aid, and then we take it back straight away, probably tenfold over. So I think actually that partnership and reciprocity is incredibly important. So thank you. Next speaker, Professor Augustin Kusamayati, who a dear friend and colleague, President of the Asia Pacific Academic Consortium for Public Health, and also at the University of Indonesia. And she's going to be talking about public health workforce training now. Thank you very much, Augustin.
Thank you, Rebecca. Good afternoon, everyone. Thank you so much for the organizer to invite me to share some of ideas telling the situation of public health education, higher education in the Asia Pacific. This will be the outline of my presentation. I try to finish my presentation in 10 minutes. First, I want to share the situation of public education, higher education in the Asia Pacific region. We have these sorts of education starting from bachelor degree up to doctorate degree. The variation is very wide in terms of learning outcome, entry requirement, the curriculum, teaching and learning process, and also the job tasks and job opportunity of public health graduates from this higher education. So the big challenge, especially for Bachelor of Science in Public Health, because they are willing to work after finishing their school, is because there is not a specific competence that they can have, that every potential employees know that they have that specific competence. This is a very big challenge of education at the bachelor level. The other things, this situation have result in a very tough competition among the graduates compete with other graduates from other programs. And we can understand that the potential employers prefer to have those with a very strong competence in a very specific subject resulted from a specific monodiscipline programs rather than public health that consider as a multidiscipline programs. While actually, as a public health profession, we face this situation, the challenge. First, of course, our experience dealing with COVID-19 pandemic, we know that the problems is they know no border. So that's why the most important competency of public health workers is to conduct borderless collaboration between countries, between regions in the world. So that's why we need to equip the public health workers with the capacity to work in a good collaboration with other professions all over the world. The other things is the challenge that also raised from this pandemic, that we need more understanding about, for example, health financing system, health science and technology, research, higher education to support research and development, as well also to involve industry in health development. So this is one of the challenges. The other things that we have to face as an educational institution is the characteristic of our recent students. They are from the 21st century students with these characteristics. They have their own ideas, their own perception on what they are going to be in the future. They want to work worthwhile, anywhere, anytime. They do not want to stay in one place. So that's why we have to support them to have their dream come true. It is how we can give them the skill that they need to be success in the world. One of the important things is the ability to work with data, to work with information and communication technology. This is a must that we have to give them. We also have to empower our students with transferable skills that will allow them to face the very fast-changing world. To do that, we have to make our students as the global citizens. So there is no other choice for us than we have to collaborate each other to provide the best education to them. The other challenge also comes from the industrial revolution, that information and communication technology come to all aspects of our life, including also in health. So ICT use very much in our field, in the health. So that in this case, our graduates, our public health workers also have to have the capability to deal with this ICT. We have many opportunities to develop or to use ICT in e-public health, for example, and these require public health workers that have the competence to work with this technology. So one of the most important things is how we include the digital health content in the curriculum. I give you an example. This is just recent in Indonesia for the standard core curriculum of Bachelor of Science in Public Health. We include the digital public health in the standard curriculum. So these are some insights for possible solutions. First is about relating with the future landscape of the public health higher education, international public health higher education. We have to develop a program that inclusive, equitable, and responsive to global humanity challenges in such a way so that our graduates have the capacity, have the competence to face the problems, the very fast-changing world, and then to collaborate with their colleagues all over the world. So we have to strengthen collaboration among us. There is no other choice. And then we have to create global citizens to enhance the capacity of our graduates, enhancing the connection between educational institutions, and of course, put the best interest of our students. this will be our future outlook, that now we have to update our curriculum to allow multidisciplinary learning, and then academic update to promote emancipated or independent learning, so that the students, they have some flexibility to choose by themselves what they are going to learn. The other is to strengthen student-centered learning, strengthen internship, community engagement program, strengthen partnership with all partners to provide the best learning environment to our students. And of course, we have to promote collaboration between the staff. Last but not least, of course, we have to use information and communication technology in all aspects of education and also in our university governments. The other more important things also is to build global competence to our students so that they can work together with their colleagues worldwide. This is some perspective. For example, this is an example of Universitas Indonesia students, what they need to make themselves more confident to work internationally, collaboratively with other graduates from other countries. For example, they need more exposure to international community, strengthen entrepreneurial skills, for example, and then also more multidisciplinary subjects in the courses. This is only some of the ideas of our graduates. Now I'm a little bit talking about my organization, the Asia Pacific Academic Consortium for Public Health. This is the way that we do. We are in the process of doing this, how we can give students the skill that they need to succeed and helping them grow the confidence to practice. First, we need to assess what are actually the tasks, the possible roles of our graduates. And then based on those tasks and roles, we can redefine the competence that needed to be given to our students, and then we develop relevant curriculum, relevant teaching and learning process, and also we can provide a guideline to be used by the members of the APEC when we are going to develop our national or our institutional curriculum. The second thing is we thinking of giving our students the skill that they need to succeed in helping them to grow and confidence in practice. For example, develop the postgraduate professional education. This is very important to equip those who are graduating from Bachelor of Science in Public Health. Professional education will ensure that they have a very clear skill, very clear competence. And then develop creative and innovative student-centered learning, strengthen and build faculties' capacity, develop integrated and comprehensive evaluation methods, and last but not least, mutual recognition agreement for public health workforce within the region. I think we have already the system for nurse, for example, for medical doctors. Some of those professions, they have already the mutual recognition agreement. And this is very important, how we can equip our students with a good sense of data, information, how they can manage, share, and use in a smart ways. Digital public health or digital health is very important to be included in the curriculum and to give our graduates with a very strong competence using information and communication technology. And last but not least, let's be connected each other. Let's develop mobility programs that give the best opportunity of our students to go and to learn in our institutions, develop and promote emancipated education and independent learning. Micro-credentialing will be very, very important to make our graduates more confident with their competence. So all the mobility programs, exchange programs, university partnership, if possible, let's develop what we call as a regional multilateral collaboration, besides only bilateral collaboration. I think this is all what I want to share with all of you. Thank you so much, and I return back the floor to Rebecca. Thank you.
Thank you so much. And as you can see, we're going to have a very wide-ranging discussion. I'd like you to keep your notes, remembering for those of you who've come into the room late, we're going to have an online discussion. We're going to bring you together in groups at your tables and have some discussion after this about solutions going forward. Now, the next speaker, Professor Rahina Joshi, who's a Global Health Research Lead from the School of Population at UNSW, and she's going to start talking about community health worker training. Thank you.
Thank you, Rebecca. Thank you so much, and thank you all for... Oops, that's gone a bit too fast. So moving on from professional training to looking at innovative solutions to address some of these health workforce challenges. So this slide is from the Global Burden of Disease study, which looks at the density of physicians per 10,000 population. And you can look at the colors over here. The countries in red and orange show a very low density of physicians per 10,000 population. What this slide does not show is maldistribution of physicians within countries, wherein the concentration of physicians, even in Australia, is around urban and metropolitan cities, while rural and remote regions lack access to physicians. The next slide is also from the GBD study, now looking at nurses per 10,000 population. There are less reds over here, but again, you can see a lot of oranges and yellows indicating the lack of nurses in these countries. The same study then estimated the number of doctors, nurses, health professionals needed to reach the UHC target, the UHC coverage index. And what it found was that in order to reach 80 of those 100 UHC coverage index, the world needed 21 physicians per 10,000 population, around 71 nurses per 10,000 population. So in 2019, the GBD studies found that the national health workforces fell short of these thresholds by 6.4 million physicians and 31 million nurses. Now, please note the timeline. It is 2019, pre-pandemic. What's happened, we've heard Professor William May talk about what happened post-COVID. These numbers now are a lot stark. And there might be a lot of new research which talks about different numbers, but the bottom line is that there is a need for increased financing, training, employment, and retention strategies for health workforce. Alongside, there's need for innovation to attain universal health coverage. And we heard about some of the solutions that Professor May alluded to in his talk. So I'm going to talk about some of the research that we've been doing to address the need for health workforce within the domains of training, retaining, and sustaining the health workforce. We'll begin with training. Being based at a university within the University of New South Wales, I'll talk about formal population health training through bachelor's, master's, doctoral studies. But we know that university degree may not be accessible, affordable, or available to everyone. So I'm going to now talk about partnering with government to strengthen the community health workforce. And the example over here is from Fiji, where the Ministry of Health and Medical Services, together with the School of Population Health at the University of New South Wales, the George Institute for Global Health, have been working in partnership to address some of these needs about providing universal health coverage at the community level, with acknowledgement to DFAT, who supported this work. So we did this study last year to understand the role of community health workers, how they can link populations with health systems and provide some of this access at the population, at the community level. That study showed huge gaps in their training, in the implementation of the program. And based on those results, the ministry then decided to revise the training program. And we are so privileged to work with the Ministry of Health in Fiji to revise this program using the approach of evidence-based and a human-centered design, listening to community health workers, their supervisors, the ministry, co-designing with the key personnel. So some of the pictures that you see on this on the slide today show some of that co-design workshop, wherein they told us what they need in terms of the community, what they can and cannot support. The idea is not to just produce training modules which then are neither scalable nor sustainable. The idea is to embed this in policy with the goal of implementation for sustainability, for the ultimate goal of improving access to healthcare at the community level. We've heard about immigration and retention. So my next slide, couple of slides are around how do we retain health workers, be it through formal training or informal training, how do we retain them within the health system? So this paper was led by my colleague, Dr. Sikambuzo Mabunda, where he looked at the retention of skilled health workers using return of service schemes. So these are medical students or students who are doing health service education who are sponsored by the government, and they go into a contract that after their education, they will serve the government. So what Dr. Mabunda did was he looked at 10 years of data from 4 Southern African countries and tried to understand the effectiveness of this. There was no formal study done before. What he found was there was very poor data on health workforce. The second thing he found was that 75% of beneficiaries defaulted the return of service schemes. And beneficiaries who undertook internship outside the training area, outside the turning, or outside the funding province, they had higher defaulter rates. We then looked at the pattern of emigration of doctors across the world, and we presented this in a paper last year, which basically shows the recommendation from that paper is that high-income countries, including Australia, must decrease their reliance on international medical graduates, especially from countries with critical workforce shortages. We've got a WHO code, which again was referred to in the earlier talk, but it is voluntary in nature. How do we change that such that there is mutual agreement? We need to have partnerships to enable workforce training and facilitate circular migration. Governments must plan and invest in healthcare teams with diverse skill sets. So moving on from retaining to now sustaining the workforce. Sometimes with lack of physicians or lack of nurses, we really need to think about innovative solutions to provide access to healthcare, to provide universal health coverage. And so my next slide is about some of these innovative research designs that we've been doing for the last 15 years or so. So these are models of care that employ non-physician health workers like community health workers as part of larger primary healthcare teams. We know that these models of care have successfully managed conditions from maternal health, infectious diseases, HIV, and tuberculosis, but they've also been used to support patients for adherence to therapies. These models of care have now more recently been used to screen and treat patients with chronic diseases and risk factors. So the first paper over here refers to some of our work based at the George Institute for Global Health at the University of New South Wales, where we trained community health workers to screen people in communities who had high risk of cardiovascular diseases. Well, they did that, and they did that really well. A few years later, we advanced this particular intervention. So not only did community health workers screen people within the community, they referred them to the primary healthcare doctor and followed them up back in the community. The third example is led from Monash University, wherein Professor Amanda Thrift, with a large number of collaborators, put together this research wherein we trained community health workers to educate people in communities, those who had high blood pressure. And what we found was we did not provide any medicine, but just by community health workers educating people in communities, that form of trust bound with the community members listened, and we saw a drop in blood pressure to the effect of 1 blood pressure lowering medications. So these models of care are feasible and they are effective. I'm going to move on to my last point over here around, yes, workforce is important and we need to strengthen them in terms of care and prevention, but we also need to have robust health information systems. Health systems cannot function until we have good data. And so this refers to, it's not research, but it's implementation science. It's called the Data for Health Initiative, funded by DFAT, by Bloomberg Philanthropies, by Gates Foundation. Again, I've had the privilege of working across with leadership from India, Philippines, Papua New Guinea, and Solomon Islands, wherein the countries have taken the leadership to change or to strengthen their health information systems. We train and support nurses to register births and deaths. We train doctors to certify causes of death. And where deaths occur at home, which is 60% of deaths in most of the countries in the region, we train community health workers to do verbal autopsies to understand causes of death. So not only are we trying to count births and deaths, we're trying to understand causes of death so that the government can make health policy and planning and health systems which is truly responsive to people's needs. So bringing it all together through research and education, the idea is not to just focus on the challenges. Absolutely, we have to use that as our inspiration, but look at opportunities to strengthen the health workforce by training, retaining, and sustaining the health workforce through equitable, trust-based partnerships across the region. Thank you.
Thank you, Rahina. And again, I think we come back to the concept of knowledge exchange and reciprocity, but many of these concepts around community health worker training, high-income countries in the region actually with major challenges to primary health care, the opportunities around community health workers actually resonate with us, and actually they're models of care that we need to look at and learn from and adapt. Our final panellist today is John Caldor, Professor at UNSW at the Kirby Institute. He's now going to move to talking about research training. We've talked about health professional training and shortages across the region and public health training. John's going to talk about research training. So over to you, John.
Thanks, Rebecca, and thanks to you and Dragan and for the organisers for the opportunity to participate in this important session. In fact, as you've heard from all of our speakers, there's elements of research underlying all of the aspects of workforce training in health. And Rahina made a comment just then saying it's not research, it's implementation science, but you know it's all part of that spectrum. But I'm going to be focusing on more specifically on the research aspect of the workforce. But of course, it does interlink with all the themes that you've been hearing about up till so far in this session. As Rebecca mentioned, I work at a place called the Kirby Institute, which is focused on infectious disease research. We've been collaborating with many countries in the Asia-Pacific region. I think we're currently collaborating with at least 5 Pacific countries and 5 or 6 Southeast Asian countries on actually different forms of research and also implementation of projects which involve an evaluation or research component. So what I'm going to reflect on is a little bit is how to base that experience, and that experience has really led us to really thinking a lot about how our responsibility as research collaborators is not just to deliver the research, it's also to support the countries that we work with and find ways to enhance their own research capacity and research workforce. And we're talking about countries with a whole, as we heard this morning from Adiba, a huge range of capacities and types of countries in our region, probably the most varied region of the world. We have countries of just a few tens of thousands of people and countries with 1 billion people. So, and every range of capacity in between. So the comments I'm making, of course, need to be interpreted in a very broad context of that diversity. So, overview, I'm just going to talk about very briefly under each of these headings, the needs for research capacity in the region, what are the issues that are confronting, and some of those you've already heard about, alluded to in different ways. What are different models that have been used for research training? What are the gaps, and what might be some approaches to help enhance our research building? So first of all, the needs for research capacity, I think this is where we sometimes get a bit confused, because at different levels of the health force, health workforce and health policy area, there are different needs, and not everybody, of course, has to be a professional full-time researcher, and not everybody can be. And so what sort of research training do we need at different levels of the workforce? So at the most basic level, I think it's fair to say that everybody in the health workforce needs to be aware of both research methods, because they are often asked to be to contribute in various ways, and also what are the outcomes of research, so that they can actually the evidence, how do they interpret evidence, how do they get fed evidence, where does that evidence come from? So basic awareness, I think, is really important at every level in the workforce. But secondly, we do need specifically, and I think this has been alluded to by Augustine and the other speakers, we need people in different parts of the workforce, particularly often in government, who can actually do research-like activities in their planning and in their evaluation of programs. And those sort of skills, those people wouldn't necessarily call themselves researchers, but they need research skills. And then finally, we need to also have, as far as possible, a self-sustaining national research workforce. And this is something which many countries have tried to build up, and you heard from William about how FNU's building up these programs up to the PhD level, but many countries are not at that level in the Asia Pacific region, or just starting to emerge to that level. So how do the various countries that work in partnerships support countries develop that sort of capacity? And what a number of issues that are brought to bear. I think there's still an open discussion about what should be the scope of research training, and we hear a number of bilateral partnership funders, including DFAT, actually say we don't fund research. So we don't fund research training as such. So I mean, they fund programs that have a research training element, but it's something it's really hard to sort of put on the table explicitly. Some other development partners do. The UK, the US development partners are more explicit about funding research, but certainly in Australia it's something that's been a little bit difficult to put on the table, and therefore research training is equally difficult to bring into the picture. So I think we need to be very clear that the sorts of things that we want to see supported are limited in scope to a certain degree. They're not every kind of research that going from the most basic science or discovery science. But we definitely need to have research on the clear agenda. Another question is who should receive that training, and I've already alluded to that, talking about the different types of research skills that are needed. But also we have this question of the pipeline. How do we identify the people who are most appropriate to be supported, for example, particularly for higher degrees, PhDs, master's levels in research? How do we know, how do we make sure that those people are being encouraged and supported? And it's often really hard to know in any country, but particularly in countries where people are in the health workforce already have strong demands on them from a whole range of other areas. One thing I think is really important is how to make sure that research doesn't either compete with or get in the way of programmatic needs. And that's true everywhere in health programming, but it's particularly true where there are more limited resources and there's a question of, okay, you want to do some research, but we've got to do the program. So how do you make sure there's the right balance there? And then the big question about funding of research training, which, as I've alluded to, is not always straightforward with some of the different partnerships we have. Over the years, I've been working in different partnerships, and the Kirby Institute and many organisations represented here, I'm sure, have the same experience. We've tried various different models and been involved in research training at a number of different levels. And it's horses for courses, and you do need these different versions, but they all have, you also shouldn't expect to get something out of one model that model cannot deliver. So at the most basic level, I'm sure all of us have been asked at some point either to attend or to deliver a short course in research methods. And at a very basic level, that's fine to open people's eyes, but it doesn't obviously deliver researchers as such. Maybe in people who already have some experience in the field, short courses can provide specific skills that are helpful to enhance their existing capacity. What's become more common, and we've delivered a number of these under DFAT funding and other funding, are short courses where you have several blocks of training over several weeks, but then the people who are participating go out into the field and actually do a research project. So actually, because as we all know in public health, learning is by doing. We can't hope to impart skills simply in the classroom. People actually have to be out there and learning how the pitfalls of research by doing it. So that's become more and more the way that we've tried to deliver our courses of the more limited nature. And this, of course, the field epidemiology training programs, which are not really called research courses, but really have research methodologies at their core, have become, and these courses have been supported by DFAT and other development partners, and I think are really important, and they're essentially doing the short courses with extended field programs, but on a sort of a more expanded scale. And then at the final level, you do have the doctoral training programs, and they're a much more limited intake, but they're the sort of approach which you really want to make sure that you're finding the right people to be supported in the right way and to get to where they need to get to. So what are some of the gaps? I mean, I've already alluded to some of the issues that arise with these different models, but there are a number of factors that we've seen over our experience. I think we've successfully supported doctoral students mainly from Papua New Guinea, Indonesia, and Thailand. We've just enrolled our very first doctoral student from the Pacific, from Fiji. Even though we've been collaborating there for a long time, it's a long pathway to make sure to find the right people and to support, but also to support the countries and make sure you're not doing what we've already heard about, taking people out of the country who are in important roles and making sure that they're supported to continue in those roles. As I've alluded to before, I think that we need a clearer consensus on what research is needed for public health, and also what its role is in relation to programs and at the different levels. And alluded to, I think also by Augustine, is where does research fit into people's career paths? What are the skills and how those skills actually described and quantified at the different levels of people's career paths in different countries? One thing that I think a lot of our research training has lacked and really needs to be built up, and we hear all about co-design and related issues, we don't ensure that research training emphasises the linkages with both community and with government, which is absolutely essential in public health. We teach the technical methods, but we don't teach enough about it. We don't impart enough about those strategies. Of course, it underlies everything we do in public health, but somehow it's underemphasised in research training. A lot of people have to figure it out for themselves, often by going down the wrong path sometimes. I think the really key point for me is that we don't integrate research training with country needs and the context. So often we see Australian institutes, and I'm just speaking from representing an Australian institution, we often feel like almost we're in competition with other Australian institutes to find people to train for doctoral programs, that kind of thing, which I don't think is particularly helpful. We should be thinking more as a collective, as institutions, what is going to benefit partner countries, and how do we work together to make sure that that's delivered in the optimal way. And that relates to a number of the other points I've been making. And then that also brings back the issue about programmatic work and research training. How do we make sure that the things that are happening in programs are tightly linked to the research? And so that's I think ultimately the only way that we're going to really enhance the relationship between the health workforce and research training. So just to summarise, and I think I'm probably about the end of my time here, a few points here that they're not revolutionary, just a few suggestions to how our thinking might be enhanced to make sure that the idea of research is properly integrated into the health workforce training. First of all, I think we do need to more formally recognise that research training is an indispensable and essential part of all global health strategies, both in country and certainly with development partnerships, and how to actually, so where does it fit in strategically? I think we need to be much more explicit about that and not sort of shy away from it. And we might call it implementation science if we like, but it is a research methodology. We need to more closely link programmatic funding with research training. So we often see that programs are supported and delivered. Every program that is delivered is an opportunity to provide research training. And so if we can make that linkage closer, then we can ensure that people who are involved in research, being trained in research or doing research training, are doing something which is actually relevant to programmatic delivery as well. Often we see, especially with doctoral programs, we see that people are sort of scratching around for a topic or without funding, whereas there's a whole program being delivered which could provide that opportunity. I think it's really important that organisations such as ours, and certainly the development partners from places like Australia, need to be working with groups like FNU and in-country organisations to make sure that so that we're not taking people out of so we're actually enhancing the capacity of, or supporting the capacity of in-country organisations where they exist and where they're willing to undertake those partnerships. I know there's been some strong partnerships of that kind already at FNU. So this is a specific point for us, and I think other universities in Australia face the issue that under certain doctoral programs are really quite strict about having people come to their universities and sit there and work for at least a substantial proportion of the time. And if you're going to get a scholarship, you've got to come to our university. I think we have to help the universities to move past that model and realise that having an impact is really about having people in their own settings and working there and supporting them to do that. So I think that's something which, as a university, I'm actively trying to pursue that, and I think it's something under the Australian system we need to try to find ways around that. So that's it for me, and thanks very much for the opportunity.
Oh, this one's working. Thank you very much. We're now going to move to a panel discussion, but then we are going to, I think I might get Dragon to click on the, we might move to our, should we put our little thing up so people can start looking at that? We're going to have some questions. I mean, I've got some questions, and I think each of us can ask each other questions as well. I'm hoping that through our electronic communication, you're going to actually have input from the floor. What I'm really interested about, William, I think you spoke really eloquently about reciprocity, and I think I completely agree about ethical recruitment and actually having policies, and I think we do need to actually look very seriously about how we manage that. But coming back to that last point from John about research training, Fiji has made huge grounds in terms of creating a sustainable research infrastructure. But from your perspective, looking at research training, what is needed to build a successful research infrastructure in Fiji and in the region? What are your needs there? What do you think is needed?
Thank you very much. Not an easy answer, but for small island Pacific countries, and I'll talk very broadly, inclusive of Fiji, health workers wear multiple hats. Yeah? They just don't do one single thing. Yeah? And research added on to them is another burden, another new hat for them. So I think whereas institutions like obviously Papua New Guinea, well established, and Fiji with the Fiji Institute of Pacific Health Research, FIPA, under the College of Medicine, Nursing and Health Sciences are two institutions in the region. I think to support the research, the workforce is really an issue. We are just developing our human health workforce research capacity through partnership, meaningful partnership with programs that are either funded by NHMRC or other George Institute or other funders to provide capacity building, in the country. But the model we really want to work is, it has been alluded to, like social responsibility. The priority needs for the institutions as well as for the country need to be addressed, and most of those programs need to ensure that whatever the research is that is going on in Pacific Island country need to have a component of local capacity building. And what we would like to see really is a doctorate student in the country, local, also partaking and included in the program, apart from whoever elsewhere, as a partner institution doing the same program. So it depends on what we're talking about. If it's through projects, that's what we would like to see, but there are multiple layers of where this capacity could actually be handled. So that's short
Yep.
outing thing.
And there's obvious pathways there as well about, again, when we talk about advocacy, looking at research funding, who can apply for research funding as principal investigators from one institution. So obviously there's a whole lot of can of worms there that we could delve into. But again, I think it does come back to funding, making sure that there's local PhD students enrolled and leading the research, and then growing as independent researchers in that country setting rather than high-income students coming in doing work on a country. Again, I think we understand that very well. Augustine, for public health training, you've talked very much about the competencies in the region. What do you think about, the changing workforce and the competencies? How generalisable do you think they are globally, the public health competencies? Should we be working more closely on competency development at a global level? You and I are both members of the global network of academic public health consortiums. There's actually 7 consortiums of public health institutions representing pretty much every school of public health across the world, but we tend to develop our competencies in regions. Do you think there's a need to actually look at this from a global perspective? And are they that generic? Should they be more specifically developed at a regional level? What are your thoughts on that?
Yeah, I agree with you. I think there are several regional networks of academic public health. So within the regional network, we have to collaborate together to do the assessment and develop together let's say, a standard curriculum as a guideline for the members. But between the regional networks, it is very important that we have also a communication and then to work together to see to see the situation and develop together what we call as the core competence of public health workers. And then later on we can adjust that core competence to our specific problems in the region and also the specific problems in every country. But I do agree with you, we have to strengthen communication between networks in the world.
Now, I might just cut to each of you just for a quick answer to this. If you had a wish list, thinking about all the things that we've talked about in terms of strengthening the health workforce in the Asia Pacific, if there were 2 things that you could do or recommend, what do you think they'd be? In terms of actually trying to reduce that, as we've said, the brain drain, the exchange of, the health professionals being trained, as William talked about. Rahina, you've talked very much about the community health worker training. What do you think the immediate things, and we're going to actually come back to the audience soon for your thoughts on that and coming and actually putting them up and actually thinking about what we should do. We know what the challenges are. Now we want to come to solutions. What do you think the solutions might be, Rahina? And I'm going to put you on the spot.
All right, now I'll go with my passion of community health workforce. It's not just based on resource poor settings, but across globally, because we talked about community engagement. They are the ones who will link communities to the health system. So absolutely across the globe, can we please strengthen community health workers? And please remember, they are not cheap labor. So provide them with adequate salaries to support them equitably.
Thank you. William.
Yeah, my first take on this is, if you're thinking about telling us that we need to pay them better, that's like, say, telling us, let's do this in the next decade or, in the next century. So that's not the answer. The answer really for us is we just need to keep on training and training and training more and to be supported, because we will not be able to prevent this. So training is a must, and we continue to, to do this, keep on doing that. The other thing is there are low-hanging fruits that can be done easily in terms of the working environment. I don't see the reason why, knowing very well that there's a predominance of women in the workforce and we can do very, gender attractive, policies, for example. Why can't ladies in Pacific Island countries be allowed to go on a part-time, half-time, quarter-time equivalents to work whenever they want to? These are low-hanging fruits that, that we could do. But I would still encourage training, and we just continue training. Yeah, thank you.
John, your thoughts?
Yeah, I'm just focusing back to the research aspect. I do think we need to break down that sort of that barrier or that perceived difference being made between programmatic support and research support, and really recognise that there are opportunities for the two to enhance each other. That you get better programs if you can build in the research side of it. Whatever you want to call it, research, but it's evaluation. It's all those skills that Agustin was talking about. And by the same token, that would provide a framework or a basis from the programs to actually allow the research side to be supported, and you wouldn't be artificially trying to create research training opportunities outside of those programs. Thanks.
Augustine.
Yeah, I expect that we can develop a stronger collaboration among networks in the globe. I know we have the global network of academic public health. Maybe GNF can facilitate the communication among the regional networks. The second thing is responding to John's presentation. What is different between public health professions and other health profession? Other health profession, their clients is individual person, while public health is community. When we are working with community, the first thing that we have to do is to diagnose the problems. And since the problems is in the community, the methods should be research methods. So research capacity will become one of the very important core competence of public health. So I think we have to work together to include also research capacity in the standard competence of public health workers, and then also to make it include in the curriculum. So I think that's my hopes, my expectation. Thank you.
Thank you. Okay, back over to you, Dragan.
Thanks so much, Rebecca, and to the team. Thank you for setting the scene so wonderfully. So I might, if we can, just change over slides. So I know we're after lunch, and so we may have the post-lunch slump. So now we're going to turn it over to you guys. So many of you will be familiar with Mentimeter and Poll and whatnot. So we're going to hand over, I guess, the next 10 to 15 minutes. Ideally, we were hoping that you could work in your groups on your tables, but feel free to work in your groups against the walls as well. But you can either scan the QR code or enter that wonderful URL, pollev.com/Dragan Illich 403. It doesn't roll off the tongue, does it? But really, what we'd love you guys to do now is work in teams, and you've heard the problems, you've heard potential solutions. We'd really value your input now. It's all about co-design and seeing what we can do moving forward. So if you can work in your groups for the next 15 or so minutes, feel free to pop up your solutions, suggestions, questions, and we'll utilise that to go through the next portion of our panel discussion. So feel free to pop up. I'll buy a coffee for the first person who actually can get us up and running. How about that? Oh, no. As soon as I say that, it's gone to safe favour mode. So we'll give everyone maybe 10-15 minutes. We'll let the panel recover for a little bit. Glass of water. Oh, no, I can't. Sorry. No, it's a different one. That's a different one. Yeah. Well, here we go. We might get the QR code. Our wonderful technician may get up and running. In the meantime, I'm a little bit old school. If technology doesn't work, have a chat amongst yourselves. We'll roam around and we'll be able to work through it. In the meantime, while we get the technology up, like I said, we're going old school, so happy to roam around. And if anyone's got any questions that they want to ask our panel. Yep, okay.
Hi, my name is Joel Negan. I actually just put it in the chat because I wasn't sure where else to put it. But William, you mentioned, and I really like the idea of the bilateral migration agreements so that any workforce that comes, there's a reciprocal model, whether that's sending people back or training or some model. I was wondering, are there any models of bilateral migration agreements for health or any other sector that you know of that could be used as a model, or is this a kind of new model?
Fantastic.
The reciprocity, in fact, came through a local research framework that was developed in the indigenous context. And what the expectation is when you are researching indigenous communities, communities would expect something in return. Whether that something in return is in the form of not necessarily funds or whatever, just knowing, what the outcome is and how it can be implemented in our communities for our benefit. That's where I thought, well, the same could be applied, with workforce migration. I have not come across a sort of a deliberate agreement that tries to reciprocate donor countries, who are donating the workforce to, between recipient and donor countries, that reversal of the donor-recipient concept. Unfortunately, I haven't, read up a model that has worked in, regarding migration. Yeah. Sorry. Yes. Sorry.
Thanks, Joel. Just to add on to that, and I think you also showed the WHO Code for International Migration, which is a voluntary code. Couple of examples where reciprocity has worked is 2 years ago, India signed an agreement with multiple high-income countries wherein they said they will send doctors to high-income countries for a fee. So these doctors won't go permanently to that country. They'll go there and work for a while the high-income country would pay the government of India. Now that model is, I'm not sure, that happened during COVID, so I'm not sure whether that's been evaluated. But just going back to the WHO code, there are some countries who have taken that code, that voluntary code, and said, we will not recruit anyone from a country which has a critical shortage. So it's not about not allowing migration. I'm from India. I trained as a medical doctor in India. But it's actually allowing migration in a respectful way such that countries can give back as well. So there are very, very few examples, but they are there and they do work.
Thank you to the panelists for a great discussion. I'm from the University of Sydney, but I also sit on WHO's Public Health and Emergency Response Workforce Committee. And I guess I have two-part questions which are sort of linked. One is around, and William, you proposed as a solution, is around workforce planning. So I'm keen to hear what are the challenges towards national workforce planning, especially on the public health workforce side. And then the second around, when we talk a lot about training and of course bachelor's and master's and doctoral training, but other challenge, I guess, of continuing professional development, and that's really key to sustaining a health workforce. So keen to hear thoughts both from the Pacific region, but also Southeast Asia region, thoughts on both of those.
Thank you, Meru. The first question is on, sorry, just trying to get it. Is it? National workforce. Oh, workforce planning, okay. The beautiful thing is almost all Pacific Island countries have got a national workforce plan. And some are pretty new, still very new, and this year, last year, one or two probably haven't got a renewed workforce plan. But the issue of the workforce plan that we currently have is, a plan is as good as a plan in some of these countries. The implementation really of the plan and the data that is live, to change the plan is, because they are rigid. These plans are pretty rigid in Pacific Island countries. So they exist, and I know we worked with the WHS Institute, and they've got, the workforce training needs for almost, most of the Pacific Island countries. So we've got those information from a training needs perspective. So there are no doubt their workforce plans. The other issue is about continuous professional development, and this is quite true for the nursing profession. There is no dedicated funding and support for continuous professional development and training as a means of not only development but as retaining. So most of the CPDs are out-of-pocket expense for health workers in the Pacific Island countries. Yeah, so I think that's really important. And if I could just address the issue of public health workforce and workforce planning, we haven't really done good mappings across on where the areas of needs are, particularly for nursing clinical areas, and worse off in the area of public health that has not been touched, I think. Thank you.
Thanks. Just trying to, my name is Shailendra Savleshwarkar, I'm from Sydney Uni. I think we've been talking about health workforce for decades. Clearly, as you showed, we have a shortage of 18 million by 2030. Population is growing at 9%. Health workforce needs to grow at 30%. So we have a gap, whichever way you look at it. I think finding solutions, and I was in a number of business meetings with business people, how they do things in IT industry. And they were talking about how Atlassian is setting up a global capability center in Bangalore to train people in Bangalore so that they can be working here. I think we're trying to look at this from how do we get the industry, in this case, the health departments, on table? Because they are the ones who are using these professionals. We as university academic institutions do the training part of it. So we need to look at models where the rapid scale-up needs to be industry supported, the government supported, and based in the countries where the health workforce is also required. So that might be one way to think about this, is how do the market forces in this case, unfortunately market is not profit, and that's why it's difficult to really push them. But it's our job to push the health departments to do this.
Does anyone want to respond to that? That's more of a comment. I've got another question down here.
Thank you very much. I'm Afzal Mahmood from University of Adelaide. Thank you very much. My colleague has actually picked my brain. I was thinking, listening to a wonderful discussion over here, and I'm one of the drained brain 30 years ago to Australia. I think we need to think outside of the box. And I like this idea of training people in Bangalore. Why not using the private sector in Pakistan or private sector in Fiji and train the doctors needed in Australia? I mean, this could be controversial, but controversial is better than unethical. So we need to think outside. So that is, I'm actually supporting that idea. And John, Professor John, I think this is a wonderful idea, training people back home for research. 10 doctoral students of mine, only 2 went back. 8 have left, stayed here in Australia. That's another kind of brain drain. Actually, many countries, for example, I worked in Burma, and they were very adamant that they won't send any PhD student to Australia because they won't come back. So I like that idea, so just enforcing that.
Anyone on the panel want to respond? No? Okay, Dragon, do you want to just respond to some of those ideas upstairs? We've got some great ideas up on the screen.
Yeah.
Thank you, everyone who's put them up.
Thanks, Rebecca. I was going to put this to the panel, and I've got to say the audience have done this much more eloquently than what I was going to do. I'm going to embarrass myself anyway, because I was going to quote John Bon Jovi, who said, "I don't know where I'm going, but I think I know where I've been." In the sense of that first question up there in terms of reaching out to our next generation. What have we learnt from everyone that has gone forward? What do we know from now? But how are we tapping in to the next generation? How are we ensuring that, as that question says up there, promoting health training and career pathways in the early school years? How do we ensure that, and will that make a difference moving forward?
I'll just share some anecdotal evidence here of the views of young people in some of the Pacific Island countries regarding joining the health workforce. It's unattractive. The trainings are too long. The hours of work are too long. They've seen their parents done it and been there, and they say, "Mom, Dad, I'm not going to do that stuff you're doing." So it's quite difficult to convince some of the young people to do medical training or join the health workforce because of that. They want work-life balance, the current generation. So it's quite difficult to attract. Those who are passionate about it will do it. Some people have advocated for social accountability in the selection of health workforce to look at how you can recruit from students, of rural background, low socioeconomic status and disadvantaged communities. Philippines have done that, the University of Philippines, Canada as well has done some of those, and of course Australia has done some of those as well. So people are looking at some of these, and the early evidence out there is it's looking good that people are retained, and work in their communities, particularly in the Philippines. Although the duration is training, and they train along the whole spectrum, the ladder program, starting from certificate in community, nursing, midwifery, and then finally as a doctor, and they retain in their communities, sponsored by the communities, funded by the communities to work in the communities.
Any of the other panels want to comment? If not, we can move on to... No, if not, we'll move on to the next one. So I guess closing the circle, are there examples of incentives for circular health workforce migration, so how Pacific nations could attract those from Australia and New Zealand? And I guess almost going the other way and identifying, well, we understand what the barriers are. Can we understand what are the drivers for retention or having, as this question says, folk coming the other way?
Let me
Augusta,
share.
go for it.
Yeah, the situation in, let's say in my country, in Indonesia. We do not have similar problem with our colleague from Fiji, but we do have similar problems within countries. So let's say graduates from my school, they tend to work in the big cities, in urban area. No one goes to the rural areas, to the remote areas. Why? Because they can have a better life in cities, in urban areas. So in Indonesia, we have problems with maldistributions of health workers, includes also public health workers. So no one wants to go to remote areas. And that is the responsibility to the government to ensure that someone will be deployed there. The problem is the capacity of the government to employ the graduates as a government employee is very low. So that's the situation in Indonesia, that we have so many graduates, but the government cannot employ them. The private sector will employ them, but only for big cities, urban areas. So the remote area, the urban area will left behind. There is no adequate workforce in the rural area. So the problem is the guarantee of the life of the health workers themselves includes also their family. If they have the family, no one will go to the remote area where there is no good school for their children. Maybe they will go there for 2 years because there is a specific program from our government, but after the 2 years, they will go back to the cities, to the big city. So the problem is how our government, our country can boost the development in all the areas so that the gap is not so wide, and how to ensure that those who comes to go to and work in the remote area, they will have enough support, financial support, welfare support from they themselves as well as also for their family. I think that's a very humanistic reasons of those who choose to work in the better areas. That's happened also in Indonesia. Even they are not go outside Indonesia, but they prefer to go to a better areas to work. So I think that's the task of the government to overcome the problems. We cannot rely on private sectors. No, it's the government. That's my perception on the situation.
Okay, I think we've got maybe time for one more question, and then if there's a question from the audience before we need to wrap up. William, I'll go to you because you mentioned this notion of task shifting, and one of the more popular questions up there is defining new professions or new issues for the workforce shortages. I'll open it up to the panel, and John, maybe you might be able to talk to this with the research lens. I mean, is it a matter of task shifting, or how do we best do that? Or Rahina?
I'm happy to take that. I think nowadays the politically correct word is task sharing, because doctors don't want to shift their tasks to others. So I think with a view of a model of care where we have diverse skill sets, teams which have doctors and nurses, physiotherapists, as well as community health workers, and all of them need not be present, co-located, so we could make things happen, having community health workers in the communities linking with that cultural connectedness to communities and referring people to primary health care centers where doctors are available. It's happening. It happens in Australia. It happens across the globe. But I think to your point of having a different or having a different health workforce which can be part of this team, physician assistants. India has started a mid-level health worker. Again, this has not been formally evaluated to see what they are not doctors or nurses, but they are in between a community health worker and a doctor, and they basically guide the patient from screening people in the community to sending them to secondary healthcare centers. So there are these models of health workforce that are being trialed, that are effective, that are cost-effective, and also provide quality care within those constraints of having good training and supervision within the public health system.
Yeah, I think there's a whole, task sharing is one thing, but I think we probably have no idea what's on the horizon in regard to some of the digital aspects of the way the health system is going to evolve. And that relates to a number of points that have already been raised today. I mean, one being the idea that with digital support, people who didn't think that who weren't recognised as having a particular skill can actually have skills at their fingertips, or knowledge at their fingertips. And so whether that's going to lead to a whole new way of deciding who does what in the health system. And I think it's a revolution that we're seeing unfold in front of our eyes, but I just don't think we have any idea where it's going to take us. And I think the Economist had a whole section on this a few weeks ago about the AI doctor will see you, and that's obviously still some way down the track, but at a much simpler level. Obviously not replacing doctors with robots or whatever you call them, but just specific tasks that we've always been thinking we couldn't accomplish in the health workforce we can. And then also in regard to information that is at the fingertips of health workers, and getting back to some of the points that Augustine made before about how to ensure that those skills are available both for individual patient care, but also for looking at how your practice is going, what you're actually doing, and how they're going to start to feed back. And I think we just don't know where that's going to take. That's opening up in ways that I think a lot of us will be caught up in coming years, but it's very hard to know which way it'll go.
Fantastic. Thank you so much to the panel. They say time flies when you have fun. I'm not sure about you guys, but I've just realised we're on 3:30, so we're probably going to get kicked out soon. Before we do that, hopefully my next slide works, or if I can get the one with the QR code on this. As you see, for us, it's been a fantastic session. I think there's only so much you can do in 90 minutes, as they say. So firstly, thank you to the panellists for sharing your experiences. Big big thank you to my co-chair, Professor Rebecca Ivers, and also big thank you to her university, the University of New South Wales, for being the major sponsor for this session as well. So many thanks, Rebecca. And thank you to you all for your contributions. Now, as I said, we've just scratched the surface. What we've put up there is a QR code. If you wish to continue this dialogue, we've collated the information from the poll everywhere. If you wish to continue, it's just a Google form where you can pop down your email address. And what we'll endeavour to do, you can hold me to it, it probably won't be by next week, but it will be fairly soon. We'll reach out and we're going to hope to continue this dialogue and actually have some action items coming out of this session. I think the best sessions are the ones where we can actually keep the conversation moving forward. And as Sandro said in today's or this morning's session, have something accountable at Berlin as well, where we can keep the conversation moving forward. So for those of you who have got the time and have got the interest, please reach out to us. Otherwise, we look forward to keeping you all in the loop and having those conversations during afternoon tea.
Dragon, apparently that doesn't work.
That doesn't work. Well,
Email.
leave it with me. Thank you.